Good afternoon. First, I'm thanking Dr. Alsher for inviting me for this session. Uh, I'll be just giving through the conduction system pacing. It is conduction system pacing is now the state of the art. It has been standard for the past 5 years. It has revolutionized this pacing. Earlier, we didn't know where an exact site of pacing, an ideal site of pacing, was not earlier known. There were no difference between RV septal pacing, RVOT pacing, RV free wall pacing. There were not much difference. But since conduction system pacing has started, the things are slightly different. It's nothing new. The knowledge of conduction system is nothing new. In fact, the first picture is something which was drawn by Sunao Tawara. He conceptualized and drew the picture about 100 years ago. And it was found now, later that by 3D mapping work and perfusion studies, and based on reconstruction, it was found that it's almost exactly the same. So it was exactly the AV node is now known to be an epicardial structure. It's situated on the right side of the heart in the lower right atrium, close to the central fibrous body, and it's a part of the central fibrous trigone of the heart. And ways of finding or imaging the conduction system is something which is coming up. Research is going into this in a live patient. How to image the conduction system. That is not yet possible, but there are different efforts into it. And one is a micro CT is another method to try to visualize the conduction system in a live patient. And other ways are imaging software to try to make virtual image of conduction system. It is being published using specific software, using the fluoroscopic images on a live basis to try to find out or try to draw the conduction system so that we can know where we are going to plan a pacing. At present, it's a blind pacing on the conduction system, but based on an EGM. So the first description of the physiology of conduction system, how the conduction system physiologically activates the myocardium, was given by Professor Jagat Narula way back in 1980s. So, and he described the longitudinal dissociation of conduction system. But the first pacing of the conduction system was done by Deshmukh et al. Sorry for the cluttering. And it is enabled, he used a usual sheath. He pre-shaped the sheath which is used for the LV pacing, coronary sinus pacing. But now we have dedicated hardware. We have specialized catheters, C315 his sheath and a lead called 3830 lead. So basically, why pacing on the conduction system? The basic concept is that when you pace on the myocardium, the conduction velocity in the myocardium is extremely slow, and capture of the whole myocardium will be very slower, and there will be disparity in the timing of capture at different points in myocardium, causing dysynchrony. So by pacing the myocardium, you are actually increasing the dysynchrony rather than reducing the dysynchrony. Concept is that you may land up in a heart failure. So patient paced in the myocardium may land up in heart failure. And this is clinically significant in especially elderly patients because they already have diastolic dysfunction. So in such situations, pacing-induced cardiomyopathy, even though pacing-induced cardiomyopathy was not found to be of very high incidence in studies, but it is because probably the patients are not living to that. When you pace a low, for example, a congenital bleed heart block is paced throughout life, their data is not yet available specifically. So when we pace it towards the last end of the 80 years or 70 years, this may not be very significant. And so BLOCK-HF trial was the first document which showed that more than if suppose you have a more than 40% pacing requirement, you have a significantly higher chance of pacing-induced cardiomyopathy. This was also shown in ICD patients called David trial, which also showed that RV pacing was associated with increased hospitalization for heart failure. And AF incidence was also high when you pace on the myocardium. So LB pacing was received a class 2A indication since 2020. It is one therapy which came up the indication class very fast by the nature of its physiology, because it's physiological pacing. It's even used in narrow QRS with PR prolongation. So it helps allows AV synchrony programming without inducing a bi-V dysynchrony, because we are capturing the whole conduction system. And it's also preferable in post-AF ablation patients. And in fact, any ventricular site pacing should be physiology pacing in the future. And it's also there is sensing requirement. Suppose you want in an ARVD, you won't get sensing, good sensing from RV. Over time, sensing also disappears. So for a better sensing from LV, left bundle or septal pacing through the left side of the heart is preferable for a stable R wave sensing. So there also bundle pacing is good. Generally, the hardware, as I had shown, was a 3830 lead, which is a screwable lead. It's not a stylet driven lead. It doesn't have an inner lumen, unlike the usual pacemaker lead that you implant. So it's slightly different. You may have to turn it by hand. So, but it's a soft lead. It's an old pediatric lead modified. So it's a very safe sheath which can be screwed on, and usually it stays well. The stability is higher than what was thought initially. And it is delivered through sheath. What we have is a non-deflectable sheath. Deflectable sheath is now about to be available. It's a 304 69 centimeter deflectable sheath, but sometimes preferable is a non-deflectable sheath because of its fixed nature. And the use of EP system is not a must for for left bundle pacing, but for a his bundle pacing, you need to know the EGM, his bundle system, so a EP system is required. So in a his bundle pacing, which is an atrial implant, you place the his catheter and you target your pacing lead very close to the his bundle catheter. For example, this mid one is the his bundle catheter, so this is the his bundle lead. So in a you can map the system also. You can use a mapping system also if required. In a left bundle sheath, this is about 1 inch below the his catheter. So it will be much below, almost 1 to 1.25 centimeters below the his catheter. In a his bundle pacing, you need to change your EP system's high pass filter to 0.5 to 30 hertz, so that you can see an unfiltered, very good his bundle potential on your catheter, so that you can identify the his bundle potentials.